So this is really important, and we only got about 15 minutes. We've got 40 minutes left now, so I'm going to do no more than 10 minutes on this. What we want to do here is we've got the lessons learned in the booklet. We've got a really comprehensive write-up from the last conference. What we now need is probably to fine-tune that into a document and send it off to Amanda Pritchard, or give it to people like Eddie, who can then use it for camp whenever the questions arise. And I don't want to rehearse the debate, but the questions we set was what went wrong, what went right, and the recommendations to the inquiry. Just feature that in your mind, and I'll be probably is anybody writing a few notes about this or tapping them into their iPhone? Yes. Okay. What went wrong? The key things that came from that debate were the UK had not learnt the lessons from their previous pandemic planning. All the recommendations have been buried. Most of the things that went wrong with PPE, they were already there in the lessons learned. They should have had stockpiles of PPE. They weren't enacted on. So we must make sure any lessons learned from this pandemic, lessons learned from tabletops, are enacted. And there must be a governance structure where we as the public can hold them to account. Other things that went wrong is we know if another pandemic was to happen tomorrow, who would be hit the hardest? People in certain postcodes. Let's go down that route first. It's postcode lottery. And Kiran Patel so wonderfully put it to us, didn't he? That you have to put disproportionate resources into areas of poverty for equity of outcomes. You can't give the same resources to affluent communities as you give to poorer communities and expect both of them to have great outcomes. How many of you are members of the Black Leaders Forum of the Confed? 1, 2. I advise you guys to join, because it's a free organisation run by, I think the chair is still Ifti Majid, isn't he? One of our members. But I went along to their conference this year, and you'll never forget this example, so use it. Dr. Adam Rutherford gives this example about health inequalities. So we know health inequalities occur. We know they're down to 3 aspects: equality of access, equality of experience, and equality of outcome. You come to my interviews, you'll be asked, what do you understand by health inequalities? The answer is avoidable and preventable. They're all avoidable, preventable. If they're avoidable and preventable, sorry, you as a board member need to be doing something about the avoidable, preventable. And if they're down to 3 areas, access, experience, and outcome, the outcome is staring you in the face with the data. And the wonderful Nina Modi, when she was on Newsnight the other day, mentioned the fact that we don't use our data well. So what did Adam Rutherford say? In the United States, infant mortality is disproportionate amongst black and white communities, same as in this country. But in one occupation, it's exactly the same. I'll give you 3 guesses. What occupation was he talking about was exactly the same?
Military service.
You know the answer. How did you know that?
I read it many years ago.
Why is it in the military service?
Because they have equal access to service, equal and equitable.
You know something? You're the first person to get that right. And I used to give £5 in the past just to a question I asked. So because you're the chair of the flood relief, I will donate £5 extra now. But absolutely, military services, they have the same access to the GPs, to the hospitals, and therefore it's exactly the same outcome. So if you put your mind now, how many of you in acute trust? Nobody. Yeah. If you put your mind to the Ockenden report, you can go, we know what the problem is. It's equity of access, experience, and outcome. The worst maternity deaths are in which group of women in this country? Bangladeshi women. And the proof of the data was in Tower Hamlets in 2006. So that report has sat there in the NHS for nearly 20 years until Ockenden reports a national outcry on it. We've known about it, and our communities have been suffering disproportionately. If a Neil Jane was here, he'd talk to you about breast cancer. Asian breast cancer, women do not present themselves for screening, and when they do, they're worse, and they're also more prone to triple node breast cancer as well. Why is this still happening in 2023? That's our ambition. And we also know, and this is something I found out at Luton Dunstable, that in Luton Dunstable, they didn't do, how many of you do research? How many of you do, then when you do the research, how many of you request that the protected characteristics of the patients you're doing research on are collected? It often isn't collected. And it took me 2 years of sitting in on Swartz Road rounds with doctors and asking them, where's the equality impact assessment? Which groups of people did you look at? Could you differentiate between the different medication? And one doctor came up to me, one of our Asian doctors, said, Jack, I got an answer for you. I said, what's that? He said, we found out, when I did my research 5 years ago, we gave pain relief to our patients. And actually what we were doing hip transplants, we were giving the same pain relief to everyone. And yet we found that Black, Caribbean and Asian patients experienced more pain. And all we had to do was give them a better pain relief. And it's also a myth, it was in the States it was discovered, that black people, African American people, were given thicker, longer needles for injections because they thought their skin was thicker, and actually the black skin is thinner. And these are the kind of myths and unconscious bias occurs. Anyway, what went right? And I'm going to be asking you for some of the answers in a couple of minutes if I don't run out of time. Bal, can you be timekeeper for us, please? Just in case. What went right? I think what went right was Kamlesh Kunti and the work that they did around risk assessments. That went really well. Quickly spotted that BMEs.
So, Jack, just from a clinical perspective, black skin is not necessarily thinner.
Isn't it more about because the only difference is melanocytes, isn't it? So I'm just saying
So we have to be careful how we frame things.
Okay.
So,
yeah.
But I'm just saying what the research that was reported to me, it was believed it was thicker,
yeah, and that was
and it wasn't true. And therefore, it was actually, well, I was told it was thinner, therefore there should have been a different needle, but it shouldn't have been a thicker, longer needle. But we can correct that. We can correct that understanding. What went right, we're looking at. Very quickly, they spotted that, well, they didn't spot very quickly. You all highlighted the disproportionality of people coming forward for vaccinations and the fact that vaccination centres weren't where we wanted them to be, which was in places of worship, easy to access. That was corrected. So hopefully, if it ever happens again, we must make sure our places of worship open the doors quickly, and vaccination centres are where the community is, where the infections are.
Jack, in terms of that point, so I was Chief Medical Officer for Black Country, and we're the second most deprived system in the country. A lot of assumptions were made about who wasn't getting vaccinated, and actually a lot of those assumptions were baseless. And it wasn't until I started connecting with the communities to hear what their concerns were that you understand. So a lot of assumptions were made about our black communities, that they were against it. What we didn't really appreciate is the historical context. Woodbrush is only a few years ago, Tuskegee, a lot of those things. And when you engage, which is what's been lacking, then you start to understand and you build those links. Yeah. The other thing, when you say about the data, a lot of our instructions were coming from the centre. And locally, it wasn't until we looked at the data, and I think that's one of the things that went wrong. We didn't use data in the right way. One, it wasn't available quick enough. Two, we didn't necessarily ask for the right data. Three, we didn't work with our partners properly. So one of the key things we found with the vaccination program is the two biggest factors locally were social deprivation and distance from a vaccination site, which is why it's then important to have mobile sites, to go to places of worship, so that actually you take those services to the communities.
Okay, I'm now going to shut you up because you've had more than your share of this one. But I'm now going to sign up Masood to help us review our document because he's got enough knowledge to refresh it, update it. We'll share it with everyone and we'll send it to the centre. We've got one question, then I'm going to sit down and invite the next speaker.
Just one thing, within the COVID framework, we had gold, silver, bronze commands. The diversity of voices didn't sit at the gold level. And I think one learning for me is we need diverse voices at that level.
We didn't have that. We didn't pick that up last time, so that's a new point. We'll pick it up. But the one thing that Masood was saying, I was tempted to reply to him, was in our trust, very, very early on, we had people with lived experience. And they were telling us there will be vaccine hesitancy in the black community. Even before a vaccine has come out, there are WhatsApp messages going out telling people don't take it, don't join in the trials, they experiment on you. And therefore, if our communities didn't join in the trials, they weren't going to find out whether it was working for them. We need, and look, keep this confidential. So I wrote to Simon Stevens. I told NHS providers this was happening. They ignored me. They ignored me because I believe in NHS EI, and I know there may be people in here, that's why I'm saying keep it confidential. They had people in their comms departments that believed in the old theory, don't fan the flames, the myths, because you'll just promote the myths. The myths were killing people. We had to dismiss the myths. We had to go on the front foot. And by the time we went on the front foot, the horse had bolted, but we did do some good work. You did it with the COVID toolkit. You did it with tweets. You did it in your own language, putting out messages. We've learned some lessons there, and we'll use that in the future. And I'm going to sit down. Go on.
Thanks. Apologies if one of the colleagues already asked this question. I think the other thing that we found in Manchester, in Greater Manchester, was that the local authorities didn't really have a strategic engagement policy at all for South Asian community. Yeah. And that's been a gap in there. I've been talking to Andy Burnham and the others to saying, listen, these issues are going to keep coming up again in the modern world. It's COVID today, tomorrow it'll be something else. What the local authorities need to do, and the NHS and through the Integrated Care Board, they've got to have some sort of a strategic approach towards the South Asian communities where they know where the bases are. So when something happens, automatically the information gets to them. Yeah. At least the umbrella organisation, if nothing else from that side of it. That's been a massive gap in sort of actually protecting our communities. Because they were running around like headless chicken. Who do we go to?
Capture that as
in a sense on it. So I think a strategic approach has to be done in the regions, and the responsibility for that is going to be Integrated Care Boards and local authorities and others.
We'll capture that.